what job they're going to do. Cell reproduction is outlined on page 230 with the life cycles. We have two different types of cells in our body. Somatic cells, which are the cells that just have a specific job to do, that they contain the entire 46 chromosomes in the nucleus of them, unless they're a red blood cell. And then we have, not somatic cells, but sex cells, gametes, and they contain only half of our DNA, because when the male sex cell, the sperm, fertilizes the female sex cell, the egg, then we have, together they make up the 46 chromosomes, so they only have half. And that half that comes together in genetics is random and varied, so we have genetic variation due to sexual reproduction. But the other types of cells go through a process where we have interphase, where the cell obtains nutrients, grows and duplicates, then cell division, which is mitosis in somatic cells, and then cytoplasmic division, called cytokinesis, and then differentiation. The differentiation is just creating different types of cells to do different jobs. So if we start out with a stem cell when we're first born, then they're reading the whole DNA, but as they get specialized, then they're only reading parts of the DNA. So if I have a nerve cell, it's only going to make more nerve cells. Do they make more nerve cells? I don't think so. Once they're developed, they don't reproduce and go through mitosis.
Nerve cells?
I feel like...
Sometimes, but very, very slow.
Okay.
They can divide, but it takes...
Not at the rate that the rest of the cells do.
Yeah, so you can regrow some nerve cells, but it's limited and takes a long time even if you can in that area. So.
Okay. Meiosis or meiosis is the reproduction of the egg and sperm cells, and then mitosis is the reproduction of the other types of cells. Cellular respiration, and this goes into it in a great deal of detail, which I am not completely familiar with, so yesterday was all new reading for me. But respiration, cellular respiration, is just the exchange of gases. So the most common one that we're familiar with is dropping off oxygen and picking up carbon dioxide. It talks about anaerobic processes, which is the process that does not require oxygen. It's the one that's going to build up lactic acid and pyruvic acid. I looked at the diagram, didn't find it completely helpful. Tyler, I know that you're way more familiar with, what was that, Dr. Ray? No, it's Brittany.
Yeah, I can talk about it if you want.
Yeah. Because I am not familiar with the Krebs cycle. I don't teach it, so.
My sophomore year of high school knowledge.
Speak up loud, nice and loud.
So it's going to be my sophomore year of high school knowledge.
Okay.
So basically, all the Krebs cycle does.
It's a. You have to be in front of the camera to talk.
Nice and loud.
Okay. So basically, I'm just going to be real quick about it, but the Krebs cycle is how your body creates ATP, which is pretty much how all of your, where all of the energy that your cells expend comes from. So within the Krebs cycle, there's a whole lot of steps, most of which I don't remember, but the key ones is that the Krebs cycle makes a lot of enzymes, and it also creates ATP, but it also takes ATP to make ATP, which is where that, you have to eat comes in kind of thing. So once you have some energy and your cells can start to create some, and then you provide oxygen into the cycle at the third step or something, and then your mitochondria can create ATP, which can then be used to, so I think within the Krebs cycle, and I could just be BSing you guys right now, because who's going to prove me wrong? But
Dr. Bright, when she gets here.
I'm sure there's something in the book about it.
There probably is. If I'm wrong, I apologize. This is just what I mostly remember.
You did not review it.
What do you say, Mom?
You didn't review it yesterday.
Yeah, you're right, I didn't. But the Krebs cycle creates, I think, 13 ATP, and it takes 6 to create that 13 ATP. So it basically, whatever's left over can be used for the rest of the cell, and then it continues through the Krebs cycle to create more. And when that ATP is used up, it turns into ADP, which just means that it has one less phosphorus within it, and it's also recycled back into the Krebs cycle, and that ADP is turned back into ATP. That's
In the spirit of being able to prove you wrong, we have a
natural.
long history of trying to do that. It says after glycolysis and the Krebs cycle have occurred, a total of 4 molecules of ATP have been produced.
4, my bad.
2 from glycolysis and 2 from the Krebs cycle. And it is an aerobic
It does take
process,
oxygen for this to
and it's the
happen.
transfer of oxygen that's increasing or storing up the energy.
So what part was the anaerobic? Because I remember reading about it yesterday.
If
So
you-
there's 2 processes for production of energy. One is aerobic, which is the Krebs cycle and glycolysis, and anaerobic is in the absence of oxygen, and it's less efficient and produces more waste. Your body can't continue with the anaerobic process indefinitely. That's it's part of the stroke process. Not a stroke, sorry. It's part of the shock process. Sorry,
Okay.
stroke patient
Oh,
last
for
night.
hypoperfusion?
Yes, so
Okay.
if you have, if one of the issues of being in shock is that you start switching from aerobic to anaerobic, and that's one of the things that causes you problems. So.
Same thing happens when you work out. You
Yeah.
go into anaerobic metabolism, and you produce a lot of lactic acid. This is why you're sore. So,
Yes,
same-
you make half
same
as
thing.
much energy in anaerobic as you do in aerobic.
I think aerobic is the greatest producer of ATP.
Yeah.
Yeah.
And it's what we're
I
doing.
think it's like 32 out of, and I think only 2 for anaerobic.
Yeah.
But yeah, that's all I remember. So sorry if
The
any of that
chart
information
on
is wrong.
74.
Yeah, in the electron transport chain, 34 molecules of ATP are produced.
You asked me next semester. I'll be
I'm
able to-
sorry.
No, I think you did a good job. That was a good discussion. Where does this make a difference for us, probably?
Very
I thought about that a lot while I was reading yesterday.
People need oxygen.
People need oxygen, yeah.
I already knew that.
I think this is just, a lot of this stuff is just a nice to know kind of situation. If you have a basic understanding of what the body's doing, it's, I think, would help you as far as identifying what potential issues might happen. And it's in the book, so we're reading it. The next part is cellular transportation, and that's just that idea of moving things across the membrane. The first one was diffusion, and diffusion is passive, which means it does not require energy, and it deals with solutes, which are particles that are in the liquid portion of the cell, and it goes from a high concentration to a low concentration. So if the concentration of solutes is higher inside the cell than outside the cell, fluids are going to come into the cell to try to neutralize it or try to equalize it. And if the solutes are greater outside the cell, then fluids are going to leave the cell. Filtration is the next one, and the kidneys are the ones that we are probably most familiar with using that process, because that's kind of their job, is to get rid of all of the nastiness in our fluid portion of our blood through that process of filtration. I don't see where it required energy. I think that one's also
Which one?
filtration. I don't think it's an active transport. I think it goes along the, doesn't require energy. I don't see where it does. It doesn't talk too much about that one. Facilitated diffusion, it's still one that is going from a high concentration to a low concentration. Facilitated just means that it requires help, usually in the form of a protein. Energy is not required, and the number of molecules transported is directly proportional to the amount of concentration. So I'm up on the top of page 233.
I think where you get into that one is with people that are diabetic and ability to move. They talk about you've got to have insulin to move glucose.
Yes, example of a substance that enters the cell by facilitated diffusion is glucose, so that makes sense, yes. The hormone insulin is required to move glucose into the cells. So insulin would be that facilitator of the process. Good. Active transport is one that requires movement of the substance against the concentration gradient. I think they used an analogy of rowing your boat upstream. It takes energy to get it done. Endocytosis and exocytosis are processes that use the energy from the cell to move substances into the cell without the cell membrane. The one I was most familiar with and remember from my college days was the sodium-potassium pump that is required to run our muscles, to have them flex and relax. It uses energy. That's why after a lot of exercise and lifting, your muscles get tired, because that sodium-potassium pump requires energy. Osmosis is another one that does not require energy. It's passive, and again, it moves from a gradient from a high concentration to a low concentration, but it's water that moves. And they talk about osmotic pressure. And I would say for this one, we probably need to be a little bit heads up, because starting IVs and giving fluids, we need to make sure that we're making good choices there. And I'm assuming that with the advanced AEMT, if we're giving different types of fluids than what we're normally giving on the ambulance, that, I don't know, that's something I could see us coming into play. So the osmosis part, I think, would be an important one to be heads up on. So in a solution, higher solutes with the concentration compared to another solution is hypertonic. So that would be figure A is an example of occurs in permeable bag, immersed in solution. Nope, that doesn't tell me. Hypertonic means that the solutes are more numerous inside the cell. Am I right? I have to really slow down and think about this. Hypotonic means the solutes are less inside the cell. And isotonic just means that they're kind of balanced. So isotonic is kind of what we're wanting.
Well, normal saline would be isotonic.
Isotonic. And is LR isotonic as well, or?
No. You've got lactate.
Okay.
You've got a small amount of lactate in it. I believe it would be considered hypertonic.
Okay. If too much water moves out of a cell, then the cell shrinks or gets smaller, and that's called crenation. And if water moves into the cell, there's only so much the cell can hold. It's kind of like a bag or a balloon. And if it takes in too much water, it'll lyse or rupture. I think the diagram at the top of 235 does a good job of showing that. So if you're looking at a red blood cell, if the solution that it's in is hypertonic, then fluids are going to move out of the cell and try to neutralize or balance out the solutes outside the cell, so the cell's going to shrivel.
So they're actually both isotonic, going back, I just looked it up.
LR is isotonic too.
They're both isotonic. But
LR is isotonic?
Yeah, but it says there's a version of LR that is not, so D5 in L, so it depends which one we have. So
D5 is dextrose.
yeah, so if we have D5.
Is D5 what they give
D5's got a little.
our diabetics? Is that
Yes. It's pretty low though. I mean, it doesn't make, it's not like D50.
Yeah, so it says both
Okay.
saline and LR are.
So both saline and LR are isotonic, which means they have a balance. Good. Then you see the picture of the isotonic cell, which is a normal cell. You can see that little kind of donut shape. And then in a hypotonic cell where the solution has less solutes in it than what's inside the cell, water's going to go into the cell. You can see where it swells and then could eventually burst, which is called lyse. So body fluid balance is super important. I think we've all probably dealt with patients who are dehydrated, and we know that that can really kick their butts more than I think we anticipate. And when you are dehydrated, you feel like poop. There's a lot of vocabulary words, but understanding the prefixes, intra, meaning in, inside the cell, fluids is ICF, extra is outside, so that's your fluids that are outside the cell. Intravascular fluids, that's your plasma, that's the fluids that are inside your veins and arteries, your vascular system. Interstitial fluid is the fluid that's between cells. And keeping that fluid balance is a process we know as homeostasis, which is keeping the balance of basically everything in our body. The table, major mechanisms for fluid homeostasis. We've got an anti-diuretic hormone. We've got your thirst mechanism, which helps us to maintain that homeostasis. Our kidneys also play a big part. If you've got excess fluids, your kidney's gonna filter those out, and you're gonna go to the bathroom more frequently. If there's not enough fluids, your kidneys filter out less, and that's when the urine that you do pass is gonna be extra yellow, giving you also a signal that you probably need to up your water intake, and then water shifts, which I don't remember reading about that one. So our body's made of cells, and then cells come together to make different types of tissues. Different tissues are all made of the same kind of cell that do a specific job. So we have muscle tissue, we have nervous tissue, adipose tissue, our skin tissue, epithelial tissue. And then different tissues make up an organ. So when you look at the heart, for example, you've got some connective tissue, you've got cardiac muscle tissue, you've got nervous tissue, and then those tissues all work together for the heart to do the job that it does. And then when different organs work together, they create an organ system. Am I continuing to go, Jim? Are you taking over?
I was gonna let you continue to go, Amy.
Okay.
You're doing a great job.
Oh, yeah. Okay, so the first one that we read about is the skeletal system. It gives ourselves our shape. It holds our body up and allows us movement without the skeletal system. My kids like to imagine that we'd be just a big bag of yuck, and I go along with it, yes. In our skeletal system, we have tendons. They're a specialized tissue that is super strong and tough and dense. White connective tissue. So if you're out hunting and you are dissecting your animal as you prepare it to go home and take it home and eat, you'll see that white substance next to the bones that is a tendon. And then tendons connect muscle to bone. And then you have a similar strong structure called ligaments that connect bone to bone. I will tell you, I remember this because ligaments starts with L, and that they connect like structures. So bone to bone are ligaments, tendons are bone to muscle. Then you've got cartilage, which is where bones are gonna work together. That cartilage creates a lubricated, nice, smooth point of contact, so you don't have owies, it doesn't hurt when you move. It creates a nice smooth movement with the joint.
And ironically, like, so we were just doing this in physics class. There's a thing called a coefficient of friction, which is how much friction there is between surfaces. And, you know, like rubber and asphalt, you know, is one of the highest, which is why we have tires made of rubber and roads made of asphalt. But then, you know, and they're all a fraction, so like wood on wood is like 168 or something, so that's rubbing wood surface on another wood surface. Our joints is like 0.001, and so that's super, super, super smooth, unless it's not, and that's when we have problems, and that's when we have pain. And so it's a very, very low amount of friction, you know, hundreds of times smaller than normal surfaces we interact with on a day-to-day
That's
basis.
interesting.
So
Jinx, are you suggesting that there's actually friction in physics?
yes,
Next, you're gonna say there's air resistance.
yeah.
All right, moving right along.
Jump science.
Talked about the bone anatomy,
Wait, there is.
and I thought that there's a couple of good pictures on page 238. That the ends of the bones are called epiphysis, and that's where you're going to find the cartilage. And then the metaphysis are just between the long part of the bone and that very end of the bone. And then the diaphysis is the longer part of the bone. And the periosteum is that outer covering of the bone, and then underneath it you'll find nutrient vessels, blood, bone marrow, compact bone, spongy bone. Compact bone is the part that is more dense, so it's stronger. Spongy bone has lots of gaps that allows for
Bending.
some flexibility to it, but also lighter, so you're not packing around solid bones and getting tired. And then there's also small gaps in the bone that allow for blood flow. So we know that in the bone marrow, that's where our red blood cells are made, and those cells have to get out of the bone through small, basically vessels that pass through the bone. There's also a really good picture of the joints. The hinge joint that we see for our knee and our elbow. So along with the cartilage on the ends of the bones, you also have in the knee there's the meniscus, okay, and then there's synovial fluid in the spaces, and that synovial fluid also acts as a lubricant for that lessened friction in the movement. I can remember having a couple of ganglion cysts removed when I was in high school. There's coverings that kind of keep that synovial fluid where it's supposed to be, and it leaked. And I can remember my joints squeaking when I would move them because there was less friction, or there was more friction because that fluid was hadn't replenished itself yet. So carpal tunnel has to do with getting that synovial fluid, and there's swelling in there, and you can feel those ligaments kind of squeaking if that those fluids aren't there to create a nice smooth movement. You can see some pictures of the ligaments. There's one that connects, it looks like not the tibia, but the fibula and the femur. You've got your kneecap connected by some tendons, and then you can see or your ligaments, and then you can see the tendons connecting the muscles to the different parts of the knee, the different locations. A lot of times the long bones will have what are called tuberosities, or kind of pieces that stick out, and their main function is to allow for attachment between muscle and bone. 240, you can see you got the lower extremities. Typically they're made of long bones. You've got some irregular bones down in the foot. You've got flat bones. Flat bones, you're going to find your ribs qualify as a flat bone, your sternum, your skull, and their main function is to protect the vital organs below them, so your brain and your vital organs of your lungs and your heart. The long bone's main function is movement. You've got your irregular bones like your spinal cord, which is still considered to be a protective bone. Your pelvis bone's an irregular bone. All of the little bones in your feet and your hands, your carpals and your metacarpals, are considered irregular. Talked quite a bit about the different bone structures in your skull and your face. Being maybe a little bit aware of those different types of bones would be something as an EMT you would be aware of. Like you've got the sphenoid and the ethmoid right behind your nasal cavity, and understanding if somebody gets hit in this particular way, you can actually shove that sphenoid into your brain, which could be obviously not good. So understanding the structure of your skull and the bones in your face, I think would be something that just kind of have on the forefront of your mind, just so you understand maybe the nature of different traumas to the face. I don't know if we need to know all of these, but the different parts of the skull, the temples, the parietals are here. I tell my kids the paranoid parietal, if you're paranoid and got your hands up, you go, oh my gosh, that's your parietals. Your frontal is, you know, your headache. Officer occipital is how we remember the occipital bone. If you put your hands up for an officer, you've got your hands on your occipital bone. You got your manly maxilla, where you grow that mustache. Your mandible. Your zygomatic process is, let me make sure I'm getting this right here. Zygomatic process. I'm not seeing it on this.
It's there.
It's
Yeah,
on
zygomatic
page
Am I right?
42.
You got your mastoid process in the back, and all of those processes are, again, areas for muscle attachment. So they kind of protrude a little bit. So you get to talk because you've got muscles that are moving that jaw using attachments to the mastoid process. I don't know how much of these we actually need to know. The orbits are the bones around the eyeball. Your nasal septum is this bone right above the cartilage of your nose, in between your eyes. Below here, all of this stuff that moves easily is made of cartilage. And then in those bones back behind, you've got your sinuses, which are just spaces that hopefully are clear and free, but if you've got an infection going on, you're going to have some drainage from those. Your sinuses, if they get swollen, it's sinusitis, and you feel like poop and probably sound funny, because those spaces also help for creating your voice. Neck, my favorite muscle, the sternocleidomastoid, is going to go from your mastoid process to your clavicular bone, and that's going to allow for that side-to-side movement. But underneath there, you've got your thyroid cartilage, that I'm sure your cricoid membrane and your cricoid cartilage, those I'm sure are going to come into play in this class. I don't know that we're ever going to have to use it, but you can create an airway there. If you've had somebody that's had their larynx removed, or what is that called?
Tracheostomy?
Thank you. Then that's what they're looking at. That's the area where they're going to be doing that. It's a little, you can almost even feel your cricoid membrane on your throat. You can feel that little indentation there. Your spinal column, I think having a pretty good understanding of that is going to be important, because when we talk about protecting the C-spine, having an understanding of the anatomy of it is going to be important. So your first, from your skull down, your first part, top part is called your cervical spine. There's 7 of them. The top one, C1, is your atlas, and it's kind of a different shape than the others, and its job is to support your skull. And then underneath that, C2 is your axis, and that movement between those two bones allows for your side-to-side movement. I think it's important to know on page 244, the very top of that bone, and there's a good picture of it off to the side on figure 724, that's the dens, and it's just a little protrusion that kind of fits up and meets with the axis, so the dens kind of goes up into your axis. And if that gets broken in an accident, that's the hangman's break, isn't it? And that can be fatal. Not always, I've learned, but that's a pretty important one there. So protecting that and allowing your patient to have very little movement in that if you suspect a neck injury is going to be super important. The thoracic spine are the next 12 down, the T1 through T12. And in that area, you've got some, your vital organs are on the other side of that. And then the whole thing has a hole that protects your spinal column. And so keeping that from being damaged is going to be super important, because that's where your entire nerve system communicates with all of your body. And so having damage to that can create paralysis and some major issues. Your lumbar spine is the lower part of your back, and there are 5 there. And then your sacrum is one big piece. They're kind of fused together, but there's kind of 5 little sections to it. And then your coccyx, which is also referred to as your tailbone, is at the very tip, and it's another bone that's fused together with like 4 little sections. The thorax is also known as your chest area. It's got the 12 thoracic vertebrae and your 12 pair of ribs. You've got the last 2, is 11 a floating rib as well, isn't it? That are floating ribs, which means that they don't connect in the front, they just kind of stop here. But the rest of them will all come back and connect to your sternum. The connection between the end of the rib and to the sternum is cartilage, which allows for some flexibility for breathing. When doing CPR though, you probably will notice there's some breaking of those ribs. The sternum allows for some, or the cartilage allows for some movement, but if you're doing CPR adequately, there's a good chance you're breaking ribs. The manubrium is the upper part of your sternum, kind of a solid part where those ribs come together. Then there's the body of the sternum, and you're going to need some understanding of that structure, because that's where you're going to help decide on your hand placement for CPR. Your xiphoid process is just a little piece that's at the bottom of your sternum, so you have to be careful that you're not pressing on it when you're doing CPR. You don't want to break it off and have it do some unwanted damage. Page 245 is where I am, so let me make sure I'm using the right vocabulary. Your axial skeletal system is the whole center part. You've got your appendicular skeletal system, which is your limbs. So on page 245, it talks about your shoulder girdle. That joint allows for a lot more movement, just like your hip joint. Those are ball and socket joints. So the different types of joints allow for different amounts of movement. So your hinge joint just kind of has that back and forth movement, where a ball and socket gives you a larger range of movement. But then you have some joints, like the joints in your skull, that allow for very little movement, and actually over time will fuse and allow for even less movement. They talk a little bit in the book about how infants have that fontanelle and the spaces that allow for more movement, which is important with brain growth, because that is a big piece of development that's going on with infants. And so if they don't have that flexibility in their skull, then undue pressure is put on the brain. I know sometimes infants, I've had a friend who had an infant who the bones were already kind of fused when the baby was born, and so they had to go in and do some surgery to kind of unfuse them so that the baby's brain could grow at a normal rate. So it did cause him some issues, but I think after the surgery he did well. But just being aware that that soft spot is supposed to be there, you have to be careful of it, because you don't want to be poking at it, because it's got a more direct access to the brain. There's just not much there, but it's an important piece of their development. The acromion process is out here on the end. When I was reading about some injuries, and they talked about having a shoulder that was out of place, they mentioned that you'll notice that the clavicle is higher than the rest of the shoulder, and I did not get a good visual, so I Googled just dislocated shoulders, and I think that as an EMT, that's an important thing to see a visual of. A picture doesn't get it done. Oh, it's on page, figure 729 on page 246. To me, that picture didn't get it done, so I would recommend that you guys Google pictures of dislocated shoulders so that you can see it's very obvious in some of those pictures, but I think it's important to get a visual on what that might look like. So if you're responding to that as a possibility, being able to recognize it is important. So I found that helpful yesterday when I Googled it. You've got the forearm, wrist, lots of bones there that I remember carpals, you're driving a car, those are the bones in your hands. Tarsals, you're walking on tar, those are the bones in your feet. So I don't know if we're going to have to remember those, but that's some of the tricks that I use. They talked to you about the saddle joint, is that joint where your thumb is, allows for movement, articulation of your thumb. You got your lower extremities. The acetabulum is that ball and socket joint. That's the socket part of your ball and socket joint at your hip. The femur is one you definitely, it's your largest bone, and a break in the femur can be a big deal because you've got your largest artery, your femoral artery running by there. If that femoral artery gets nicked by a broken bone, you are in a world of hurt. So I know that we'll be talking about stabilizing a femur break. Are we gonna do all of the stuff that they did in the basic 2 over again, or?
Don't think we're gonna do all of it.
Okay, so you probably all recently had that class on how to deal with the different splints for a possible femur break. Your greater trochanter is that big hip bone. A lot of people will say that's huge for lots of muscle attachment going on there to allow for the movement of the leg in a lot of different, you know, your side to side and your across your body and your straight up and down. All of those have different muscles, and so there's all of those muscles attaching to that greater and lesser trochanters. Page 248 just shows a closer look at the ball and socket joint. And then some ligaments and tendons. Hyperextension is just being able to, if your leg moves in a direction that's not supposed to, so if you're in your knee joint moving it backwards, if you land on it wrong and you kind of pop it backwards, you're stretching and damaging those tendons and joints or ligaments back there. Can be painful, and depending upon how bad it is, could be something that requires surgery. Skeletal system physiology on page 249. I did pay attention especially to the special populations, the words of wisdom boxes. I found those helpful. But hip breaks are something that we might see frequently in our elderly population. I know we have a pretty good elderly population here in Thermopolis, and so we deal with possible hip fractures on a fairly regular basis. So understanding the anatomy of those. Let's see, potential break here just below the subtrochanteric, which just means it's below those greater and lesser trochanters, the top of the long bone. So talking about the muscular system on page 250, we have 3 different types of muscles in our body. We have cardiac muscle. The structure, you notice they have in the picture on 737 larger nuclei. They are very strong contractors. They do not tire, fortunately for us, so that heart keeps beating. The only thing that might cause that to stop is if you have an infarction, which I know it's covered a little bit later in the chapter. An infarction just means you got a blood clot or restricted blood flow to the cardiac muscle. But that cardiac muscle does not tire. Skeletal muscle is also known as striated muscle. It's going to be the muscle that contracts and relaxes, and it uses that sodium potassium pump, so it uses energy, and it does have the ability to get tired. So you might be lifting something, maybe you're working out bucking bales of hay, and there's a point where you're like, my muscles are done. They're not doing anything else until they rest. So they do tire. And then we have smooth muscles. Smooth muscles are found in our digestive system, and they are ones you can't control. So striated muscle, you can control, hey, I'm gonna pick this pencil up, I'm gonna move across the room. Cardiac muscle are involuntary. We don't have to think about those, fortunately, so we don't have to concentrate on keeping our heart beating. And smooth muscles we don't think about, but if you have your stomach grumbling or you're getting ready to have a BM, smooth muscle are the muscles that are taking care of moving those substances through your body, so they get to the end result and get rid of that stuff.
It also controls your blood vessels.
Oh yes, your vasodilation and your vasoconstriction are also controlled by smooth
shock.
muscle. Yeah, good deal. Atrophy is what happens when we don't use it. The muscle shrinks or wastes. Sometimes different diseases will also cause atrophy to your muscle. Hypertrophy is just when they increase in size. Some drugs will do that. Do we need to know all of the muscles? Cause there's a lot. Maybe some of the basic ones, some that they've got highlighted, your bicep and your tricep in your arms. You'll see the diagram showing a large selection of them on page 251. Do we need to know all of those? I mean, there's a ton of them.
I don't think we have to go through all of them, just so people are kind of familiar, they should know most of that.
Yeah. We probably all are familiar with our pectoralis muscles. There's a couple of layers, so you've got your pectoralis major and minor. Your trapezius are the ones in your back. I already told you my favorite one is the sternocleidomastoid, and then the sartorius is one that goes from your greater trochanter down across your knee, so it allows for that movement across your body, up and over. So if you, what's the injury? My track kids used to get it a bunch where they had a hard time lifting their leg. What is that? Help me, track kids. Jim, you know it?
You know, it's been 6 years.
Hip flexor.
Hip flexor problems,
Yes.
yeah.
Injuries to that, so. You all probably know our gluteus maximus, and it's another one that has layers. So you got the gluteus medius. Gastrocnemius is your calf muscle. Quads are in the front. Your quadriceps are in the front. What's in the back? Help me. It's not on this list, but I know it. We used to know it. But maybe just take a minute and look at page 251 to familiarize yourself with those if you haven't already. There's also a table on page 252 with some of the muscles that they've deemed appropriate. And I like this because it tells you where it is, but it also gives you a little bit of a idea of what its function is. So bicep flexes the lower arm where the tricep extends it. They have to work together, because if I flex this muscle and I use my bicep, then the only way it's going to straighten is to use my tricep, so they have to work together. If that tricep's not working or it's injured, I can flex my arm, but then I may not be able to straighten it without using the other arm. Oxygen use and debt. Oxygen is required to break down glucose in the mitochondria. That's part of that Krebs cycle. Hemoglobin is the pigment in your blood that makes it appear red. And hemoglobin is required in order to, the oxygen attaches to that hemoglobin. So when hemoglobin has oxygen on it, it turns bright red. When it's deoxygenated and it's dropped off its oxygen, it turns dark red. So understanding that, and the color of the blood that you're seeing, and then even the force in which it's exiting the body will give you some clues whether you have an arterial bleed or a venous bleed. Table 7.5, changes in muscular metabolism. That talked about your types of exercise. So if you have a low to moderate intense exercise, blood flow provides enough oxygen for the needs of the cell. That's your aerobic workout. Glycolysis results in the formation of pyruvic acid and aerobic respiration. For skeletal muscles, 36 molecules of ATP per glucose, and it does exhaust carbon dioxide, so that's why you will probably see an increase in your breathing to kind of help keep the balance. High intensity work at types of exercise, oxygen supply is not enough, so that's your anaerobic. Glycolysis will result in the formation of lactic acid. That's the one that Tyler mentioned. When you're working that way, you get a lot of lactic acid buildup, you're going to be sore. 2 molecules of ATP per glucose, so like London said, that aerobic respiration, you're going to produce way more energy than you would with your anaerobic. Page 253, the respiratory system. The diagram there shows the parts of it. You've got your sinuses, you've got your nasal cavity, your mouth, your larynx, your epiglottis, which is an important one, and you might be dealing with issues with the epiglottis when you're dealing with children. Epiglottitis is a condition that a lot of younger children might get that create that epiglottis is going to swell and create issues with breathing. So I'm assuming you probably already had that in basic EMT class. You've got your trachea, which leads to your bronchioles, that branch off to your bronchus, your main ones, and then they break into smaller and smaller pieces. Your bronchioles then end in the alveoli, which is a sac-like structure at the end of all of those bronchioles. That's where the actual gas exchange takes place between the blood and the alveoli. The cardia is that spot right there between the branches where it branches off to the right and left lungs. The diaphragm is also part of that respiratory system. It's the muscle underneath your lungs which creates the breathing, because we know that breathing is passive. So that diaphragm is going to flex and straighten, which creates a vacuum in your pleural cavity, which will pull the lungs out, drawing air into them, giving the alveoli time to fill and get the oxygen out of the blood system. And then when you exhale, you relax that diaphragm. That gets rid of the vacuum in your pleural cavities, pushes the air out.
Where I think that'll come in handy on this airway is when we talk about lower
Lumen.
multi-lumen lower airways. Essentially, when we use a BVM on someone without an airway in, what typically happens? You inflate their stomach, push a lot of air into their stomach, which can be problematic. With the multi-lumen airway,
Are you talking loud enough that the
probably not, and I
Intensity.
probably shouldn't be talking.
No,
That's
I-
probably where this atlas of the airway is going to come in handy.
Yeah, so understanding the anatomy of the airway is probably for sure going to come in handy as you learn about the multi-lumen airways, which is a skill that you guys are going to be learning. I think that looking at I know somewhere yesterday, there's a section that kind of explains asthma. Was it?
254,
Huh?
on 254.
The words of wisdom. That words of wisdom box is going to be something that I think you want to make sure you pay attention to, because asthma is something as an EMT that we deal a lot with, and so understanding what's happening is going to be helpful. It's a reoccurring condition of reversible acute airflow obstruction in the lower airway. Most common chronic disease in children. 4 distinct events occur in an asthma attack. First, you have the muscle spasm, which occurs when smooth muscle layers around the airways constrict. Those are called bronchospasms. That results in the narrowing of the airway diameter. So if that diameter is less air is getting in. Second, increases secretion of mucuses, which cause a mucus plug, which further decreases airway. And third is inflammatory cell proliferation, causing swelling of the lining of the airways, which again decreases the diameter, which decreases the amount of airflow you've got going on. Finally, white blood cells accumulate in the airway and secrete substances that worsen the mucus spasms. So you've got a multitude of things going on that do not assist in airway management. Most common cause of an asthma attack is upper respiratory infection, such as bronchitis or a cold. Other causes include changes in the environment, emotion, so if somebody gets upset, that doesn't help, especially stress, allergic reactions to pollens, foods. So that's where our anaphylaxis shock comes in, monitoring their airway and making sure that you can maintain it if you know that somebody's having an allergic reaction is super important. And then different drugs, penicillin and local anesthesias will also cause that reaction. Occupational exposures can also cause asthma. The severity of the asthma attack varies among patients. Sometimes patients are able to kind of self-medicate using their inhaler and be able to get it back under control through medication and rest. On page 255, there's quite a few vocabulary words. Tertiary different types of the bronchi, alveolar ducts, which then each bronchi divides to form alveolar ducts, and then those ducts are kind of a collection of that alveoli. And what that does, though, because of their structure, it provides greater surface area, which is important because it's going to increase the amount of oxygen that you can absorb. There's also a substance in your lungs called surfactant, which keeps your lungs flexible and pliable, and then also keeps them from kind of sticking together so that you don't have a collapse of the alveoli. I feel like, is there something that we're going to need to know for surfactant on the advanced?
Oh, you know, in regards maybe to different types of drownings, but I don't think that's
For drownings, okay.
applicable for us.
So that surfactant may come up again later as we get into some skills.
I think 256, they talk about the anatomy of a child versus an
Yes.
adult. That might be.
That is good. Yeah, the special populations on 256, talking about the anatomy comparison of adults versus children. So everything's smaller, or smaller in proportion, but so like the child's tongue is going to actually take up more space in their mouth than an adult's would, which can cause greater breathing issues if you have, it's just a larger, what's the word I'm looking for? Obstruction. The anatomy of the respiratory system in children is proportionally smaller and less rigid. Child's nose and mouth are smaller, so you're going to get less air movement just because of that. The larynx, cricoid cartilage, and trachea are smaller, softer, and more flexible as well, so that could potentially create an obstruction, or they could get damaged due to trauma. Makes the mechanics of breathing more delicate. Child's pharynx is smaller and less deeply curved. So when we talk about opening an airway on an adult versus a child, you don't want to have the child's head tilted back too far, because that flexibility of the larynx, it could shut off the airway and actually restrict airflow when you're trying to do the opposite. So when you open the airway of a child, you're not going to have as much flexion in their head. Children depend more heavily on diaphragm breathing, so if they're having difficulty breathing, you're going to notice things like that seesaw action. They're going to be more labored. The seesaw was a big one that I remember learning and reading about yesterday. The abdomen moves considerably with each breath. Young infants don't necessarily know how to breathe through their mouth, or know how to breathe through their mouths. Therefore, as you assess an infant, a child, you must carefully consider the differences. They're all little nose breathers, I guess, so getting a cold on an infant is a little bit more concerning than, say, an adult would have.
Snot suckers.
Little snot, yeah, get those snot suckers. Tyler was advanced proficient using those as an infant. Again, I encourage you to pay attention to the words of wisdom. Intercostal muscles, they're the muscles that are in between your ribs, and they play an important part of breathing. When they contract and relax, they change the amount of space that your lungs have under your ribs. This goes into detail on which parts of the muscles do what job. I don't know if you really need to know that. The other words of wisdom talks about COPD, and that's something in our population, we have a decent amount of COPD patients. So chronic obstructive pulmonary disease, COPD, is a progressive, irreversible disease of the airway marked by a decreased inspiratory and expiratory capacity of the lungs. COPD may result from chronic bronchitis, which is excess mucus production, or emphysema, lung tissues damaged with a loss of elasticity, so the lungs don't recoil like they're supposed to. Patients with COPD usually have a combination of both problems and generally function at a certain baseline level until an event occurs that causes an acute episode. So a lot of times a COPD patient are going to have a lower O2 level, and that's just kind of how their bodies learned to function. Jim, do you have anything to add on COPD?
We see a lot of it.
So we have to be careful about, can you talk about how being careful about the oxygen?
I think long-term,
Yeah,
over
long-term.
oxygenating can be a problem. I don't think short-term it's a big issue. You never want to withhold oxygen if obviously they're unable to breathe.
Most COPD is could go over 92%.
You don't want to get them above 92? And
They usually run baseline 89 to 90. Just
Okay.
working with my COPD.
And so on our ambulance, if we have a longer transport, that's when we have to kind of be mindful about paying attention to how much oxygen.
Long-term, and obviously short-term, if they're struggling, they can't breathe, they can't make oxygen exchange, we've got to give them oxygen short-term. That's typically when they fall, is that sudden onset of inability to oxygenate. And, you know, we're gonna deal with that one, but if it's a long-term transport, you're right, Shay, I don't think pumping them up to 96 or 98% does us any good at all.
So with the respirations on page 258, it just talks about the fact that our breathing is controlled by chemical receptors. So our brain, through those chemical receptors, kind of monitors the levels of carbon dioxide and oxygen in our blood. The main driver for our breathing is carbon dioxide, so it pays attention to those levels first, and then we have our oxygen hypoxic drive receptor that kicks in if it needs to, and that one specifically looks at our oxygen levels. Do I need to go into all of those, respiratory acidosis and alkalosis? Those
No, we're gonna talk about those again when we talk about IV solutions.
Okay.
And dealing with folks in.
So the pH levels in our bloodstream also play a part in helping control our breathing. On page 259, it does talk about the respiratory acidosis and alkalosis, and those are just determined by the ions of hydrogen in our bloodstream.
I was hoping Dr. Bright would be here
I
to
would,
discuss
yeah,
this.
because I'm not as familiar with this as I should be.
Then can I make a suggestion?
What?
Can we take a bathroom break and just a stand-up break for 10 minutes?
That's your call.
No, it's your teacher today,
Yeah, I just got thrown into this. Sure, and then I'll take a
Let's
minute.
take a quick break.
Make sure, take a
Take
quick
a
break.
5-minute break. So Tyler can go wee-wee.
I need to probably start bugging London.
What is it
just
over?
Skip it.
What is it over? Kinetic and potential energy, which I understand the concepts, it's just making sure that I present it in a way that other people can understand.
You
which
think
is-
that 7th and 8th graders actually know anything about it? Just make it up.
Look.
I
they're
have
children.
integrity, Tyler.
Hit the basics.
Yeah.
Basics.
Yeah.
Don't get too deep, because they won't go there either.
All
Trust
right,
me,
welcome
I've been
back. Let's get started. We're moving into, we talked respiratory system, just the idea that it's driven by our chemical balances in the body. It shows a lot of diagrams on how pH drives the mechanisms.
Talking about, I know Dr. Miller talked about the reason, part of the reason that we use LR for trauma patients is that the ringers, the lactic ringers in LR is slightly alkalosis, slightly a base. And as patients go into respiratory problems, they tend to come up with metabolic acidosis. And the idea is that it would slightly offset that.
So the LR tries to offset it?
A little bit.
Because even, didn't I read yesterday that in a normal conditions, our body runs slightly alkaline?
Yes, should.
So, on page 261, in the middle of the first column, you can see that if you have increased hydrogen, yields an increased H2CO3, which would make it acidic. We have an increased carbon dioxide. That's what it the reactions look like with tachypnea. Tachy means fast, pnea is breathing, so that's an increased respiratory rate.
Yeah, I think,
Decreased respirations through the chemical reactions will increase the H2CO3, which creates acidosis. Increased respirations, we're blowing off a lot of carbon dioxide, so it goes down, which in turn causes our H2CO3 to go down and will create a basic environment, which is alkalosis. So I thought that the increased respirations creating a basic environment, alkalosis, and the decreased respirations, acidosis, is something that might be something we can recognize on scene depending upon, or be prepared to deal with depending upon our patient's respiratory rate. The nervous system is the driver of our breathing. The dorsal respiratory group and the ventral respiratory group play a part. The dorsal is the main pacemaker of breathing and is responsible for initiating inspiration. The ventral respiratory group helps facilitate inspiration, forced inspiration and expiration as needed. So the dorsal is the one that we usually mainly rely upon, but if we are needing to take those deep breaths or blow it off fast, that's when our ventral kicks in. You can see that's all listed on the table 7.6 on page 262. Talked about lung volumes and our tidal volumes, which is the amount of air that we move in and out of our lungs. Typically it's about 500 milliliters per inspiration, expiration, that's what's moving in. But it also talked about that we've got our inspiration reserve volume, our residual volume, and our expiratory reserve volume. So our residual volume is the volume in our lungs that kind of help maintain its shape, keep it from collapsing. So there has to always have some amount of air in our lungs to maintain that, keep the sides from sticking together with even with the surfactant. Our inspiratory reserve, so if you've ever had surgery and you have the little dealy bob that you have to breathe into and breathe out of, those exercises kind of help us maintain and in some cases even increase our inspiratory reserve and our expiratory reserve. So that if you find that you're in a situation where you need to take those deeper breaths and really work to move lung or air in and out of your lungs, that your lungs have the capacity to do that. That's your vital capacity. You got some dead space in your respiratory system. Dead space is the portion of the respiratory system that has no alveoli, so that's your bronchioles, your trachea, all of that. If you go back and you look at the picture on page, well, any of them that has your respiratory, the best one to me would be even the one on 253. All of those tube-like structures in that picture, those would be dead space, because it's not till the very tips of those tube-like structures where we find the alveoli. Okay, so dead space just means that in that part of the lungs there's not actual respiration going on, there's no gas exchange. Minute volume is the minute ventilation. It's easy to understand. It's the amount of air that moves in and out of our lungs in 1 minute of the dead space. And it talks about how to calculate that. You take your respiratory rate and your tidal volume. Well, we don't typically have the tools to measure tidal volume on the ambulance, but we can kind of get a general idea just by looking at the rise and fall of the chest. You know, how deep are their breathing? Are they shallow? That's gonna decrease the tidal volume. Are they taking nice deep breaths? That's increasing the tidal volume. So we can kind of get a general idea. Typically, when you're taking a nice deep breath, you're slowing down. So your minute volume, even though it seems like it might be going down, because you got a greater volume in the air, they could still be adequately breathing and keeping their oxygen levels at an appropriate level. Characteristics of normal breathing: you have a normal rate and depth of your tidal volume. So the more practice you get at watching somebody breathe, the more you'll have the ability to kind of judge that and recognize abnormalities when you see them. A regular rhythm or pattern, so they're not kind of doing the uneven breathing or raspy breathing. You can hear it, good audible breath sounds on both sides of the chest. A regular rise and fall movement on both sides of the chest, and the movement of the abdomen.
Amy, can you tell me how do you pronounce the normal breathing word? Is it eupnea?
Eupnea? What page, where are we looking?
It's under characteristics.
Left side
of normal-
263, yeah.
Left side 263.
Characteristics of normal breathing, second line.
Oh, eupnea,
Is
that's
that
what I
right?
would say, eupnea. Would you,
Alright.
Jim? Eupnea. Apnea is lack of breathing.
Yeah, that's just a new word
Tach-
for me.
Tachypnea, that was on the other page, tachy meaning,
Tachypnea.
Yeah.
Eupnea.
yeah.
What was that?
Say it again, London.
Minute volume or where
Eupnea.
are you at?
I would just went back, I remembered the in that blue box on page
Yeah.
261 that I just reviewed. Tachypnea,
Tachypnea.
tachypnea, so yep. So asking me for pronunciation advice is probably not your best bet.
What's this word in English? This is a medical term, but breathing. How do tachypnea? You don't want to
Tachypnea.
stress on.
Well,
Thank you.
that's what-
Always, yeah, you can always ask Google. Is that what you just Googled
No, I'll
it?
do it.
Awesome.
It's tachypnea.
All right.
You gotta say it like that, Alex.
Got some fairly helpful diagrams on page 264 and 265 that they, with the breathing rate, your respiratory system works very closely with your circulatory system. They will not function very long without the other. Your circulatory system includes your heart and all of your vessels. So on the diagram on 264, you see that all of the blue vessels represent your veins. They're carrying deoxygenated blood. So if we're looking at that blood, remember it's the one that's kind of a brick red, okay? So the oxygenated blood is the bright red. Remember it's hemoglobin that carries the oxygen, but the carbon dioxide is just floating in the plasma. I don't know if I had ever really thought about that or remembered it. I'm sure I learned it some time ago, but the carbon dioxide does not attach to the hemoglobin, but that doesn't make sense because when you get carbon monoxide poisoning, it attaches to
So that's different,
hemoglobin.
because carbon monoxide has a different structure than carbon dioxide, which allows it to connect, and it's
Okay.
also more difficult to remove
Right.
than oxygen.
Because I know carbon dioxide or monoxide poisoning is gonna
is attached.
attach to the
I think it
hemoglobin,
binds to the hemoglobin.
and you can't get rid of it, so that decreases the amount of oxygen that your blood can carry because the hemoglobin's already occupied by carbon monoxide. Okay, but I guess I just always thought that carbon dioxide also attached, but yesterday's reading proved me wrong. So the structure of the heart, you've got the right atrium.
So, this says approximately 75% of the carbon dioxide is transported in the red blood cell and 25% is in the plasma.
So some of it is in, but doesn't say anything about being attached to hemoglobin, or does it?
It says it does,
Oh, okay.
but
Because I thought I read yesterday where it didn't, but I guess I also just didn't realize that there's some in the plasma. Okay. So the right atrium is the first part of the heart's chamber that fills with deoxygenated blood. And then it then empties into the right ventricle. Those two chambers are separated by a tricuspid valve. Tricuspid just means that there's 3 cusps to the pieces that kind of keep that leakage from going or not happening between those 2 chambers. Then the pulmonary valve keeps it from backing into the pulmonary arteries until it's ready. What's that?
A full official answer for carbon dioxide?
Sure.
So first, carbon dioxide is more soluble in blood than oxygen is. About 5 to 7% of all carbon dioxide is dissolved in the plasma. Second place that it's carried, carbon dioxide can bind to plasma proteins or can enter red blood cells and bind to hemoglobin. This transports about 10% of the carbon dioxide. This binding is reversible, and they freely dissociate from the hemoglobin. And then third, the majority of carbon dioxide molecules, about 85%, are carried as part of the bicarbonate buffer system, which was part of the acid base
Right.
a few pages
I remember
ago.
reading about that.
It diffuses into the red blood cells and makes carbonic acid.
So the CO2 can bind but can be unbound, but
Yeah.
the CO can bind but can be
It's
unbound?
more difficult to, yeah.
That's where you have to use positive pressure
Yeah, it
ventilation.
takes positive pressure to force it off.
Okay, so from the left or the right ventricle, blood is then sent to through the pulmonary arteries into the lungs, where it drops off its carbon dioxide. It's going to pick up its oxygen. Once it's oxygenated, it goes back into the heart via the pulmonary veins. Okay, the pulmonary veins are the only veins. No. Yes, that carry oxygenated blood. The pulmonary arteries are the only arteries that carry deoxygenated blood, because typically arteries carry oxygenated blood and veins carry deoxygenated blood, but the pulmonary veins and arteries are backwards.
But they're named by where they're going.
Yes, whether they exit the heart, all vessels exiting the heart are arteries,
Yes.
all vessels entering the heart are veins.
Veins.
So from after it's oxygenated, it enters back into the left atrium via the pulmonary veins, passes through the mitral valve into the ventricle. The ventricle on the left side is larger and more powerful because from the ventricle it's then pumped through the aortic valve into all of the rest of the body. So that's got to be a pretty powerful contraction in order to do its job efficiently. Is there anything so the aorta is your largest artery in your body. You've got your ascending and descending aorta. Ascending aorta is going to carry oxygenated blood to the upper part of your body, where your descending aorta carries it down to the lower part of your body. Sometimes you can even feel your aorta underneath your, I feel my pulse here sometimes from that aorta. It's one that if it is damaged, because it is so large, you're going to bleed out very quickly. It's usually going to be a fatal injury. Anything else that anybody wants to add about that part? Okay, so I thought that it's important for us to review the heart sounds on page 266, because as EMS, understanding what we're hearing when we assess the heart sounds in the ambulance is going to be important. So I want to kind of go over this one in a decent amount of detail. So heart sounds are created by contraction and relaxation of the heart and flow of blood. The sounds can be described as being a lub-dub. The lub is the first heart sound, or S1, and the dub is the second, or S2. The dub often is louder than the lub. The sudden closure of the mitral and tricuspid valves at the start of the ventricle create the lub part. The closure of both the aortic and pulmonary valves in the ventricle cause the dub part. Two other sounds that you might hear in some situations are the S3 and S4. So the S3 would sound something like a lub dub da, and it correlates with a fourth rapid ventricular filling. The S3 sound sometimes is present in a healthy young people and can be associated with abnormally increased filling pressures in the atria, secondary to the moderate severe heart failure. The S4 sound is a medium pitch sound that occurs immediately before the normal S1 sound. This sounds like a blah lub dub. The S4 sound represents either decreased stretching compliance of the left ventricle or an increased pressure in the atria. An S4 heart sound is almost always abnormal. So those might be something that you would hear when assessing heart sounds. A murmur is an abnormal whooshing-like sound heard over the heart that indicates turbulent blood flow. Murmurs can be caused by leaky valves. Sometimes you might even have a patient with a mechanical valve where you're going to hear those sounds replaced with a clicking sound, because the heart makes a clicking sound, or the mechanical valve will make a clicking sound when it opens and closes. A bruit is an abnormal whooshing-like sound heard over a main blood vessel that indicates turbulent blood flow within the vessel.
Do you want to listen to some of them?
Sure. Can we make sure the microphone is close enough that the 10 sleep people can hear too?
Probably not. This is best if we can get it loud as it'll go. I don't know. Okay, I can't hear it. But you can look them up.
Yeah. Just on YouTube, is that where you found them?
Yeah. And then see if I can find the S4 was the one that it was talking about.
Cardio burns fat, right?
Yes, it does.
No. Cardio actually burns calories.
Cardio is for your heart, not for burning fat. I saw that ad on YouTube.
So there's that extra S4 sound. I don't know if you can hear it, but
This is one I would highly recommend, and I will be doing it when I get home, is looking up those sounds, because you're not going to always get a lot of opportunity to hear them on the ambulance. So just maybe YouTubing it so you can hear what they look like, so you recognize them if you do hear them.
There are apps for those too that you can put on your phone.
What app is that?
This one, I was looking to see ECG Pro, it's called. And that was a free download. But it has a bunch of examples of normal rhythm in different populations, but then also abnormal or.
So CG Pro is an app that you can download for free?
ECG Pro.
ECG Pro.
Right.
Okay, so that might be an app you might want to check out and see if it will be helpful for you. On page 266, the bottom of it, it starts talking about the electrical system and how it works to regulate heart beats through an electrical system in our heart. So the cardiac conduction system consists of 6 parts. The sinoatrial SA node. And so if you look at the diagram, that one's in the atrium, at the top part of the atrium. Okay, the atrioventricular or AV node, which is also in the atrium but closer to the valve exiting the atrium. The bundle of His, so that is just next to and just after the AV node. The right and left bundle branches, so you can see down that septum, which is the muscular part that separates the chambers. You can see them kind of branch off so that you've got a pathway around each of the ventricles, and then the Purkinje fibers, which are the fibers that run through the muscular part of the apex and then back up through the ventricles. And those all signal that heart to beat. When the heart does beat, it's going to contract from the bottom up to kind of force all of that blood out of the ventricles. If somebody's electrical system doesn't work right, they can have a pacemaker, man-made pacemaker inserted that will kind of take over the job of that SA node if it's not functioning correctly.
And on the bundle branches, sometimes you'll see like bundle branch lock, and sometimes if you have the pads on them, it will tell you to shock, but they may be fine and awake.
Oh, interesting.
So Jaden has the right, my mom has the left bundle branch lock, and it will tell you to shock them.
But they have normal contractions
Yeah.
with that?
Yeah.
Oh, okay. Interesting.
So don't shock if they're awake.
Yeah, if they're awake, you shouldn't be shocking anyway,
You
but.
shouldn't be
that's-
putting it on
If
them.
they argue with you about it, don't do it.
Don't mess with me. Shock.
It is crazy.
That is interesting. Interesting. All right, so in the system, you have baroreceptors that are going to measure and be influenced by pressure. And then you have chemoreceptors that also are working with the process to determine the pace and the contractility of the heart rate and the regulation of it. Not going to go into alpha and beta effects. So cardiac cycle, I think that one's worth reviewing. Your systole is the term that refers to the contraction of the ventricles, mass and pumping of the blood into the system. Diastole is the relaxation phase of the heart cycle and is called diastolic blood pressure. A normal diastolic blood pressure is going to be between 70 and 90. A normal systolic blood pressure is between 110 to 140. I kind of try to explain to my students that on a diastolic blood pressure, the heart, or the systolic, the heart is contracted, so there's not a lot of blood in there. Most of the blood is going to be in your vessels, so that's going to be higher because there's more volume in there. The diastolic, the heart's relaxed, so it's filled with blood. There's going to be less blood then in your veins and arteries, so that will bring your blood pressure. That's going to be the lower number. So that helps me remember that the higher number is when the heart is empty. The lower number is when the heart is full. Stroke volume is the amount of blood that is ejected per contraction, and different people have different stroke volumes. Athletes tend to have a higher stroke volume, so that's why they will have a lot of times a lower pulse rate or a lower resting heart rate because their heart's more efficient because it's got a greater stroke volume. Cardiac output is the amount of blood pumped in 1 minute. Again, your cardiac output is going to be dependent upon the health of your heart and your stroke volume, your heart rate and stroke volume. So if you have a good stroke volume because your heart is healthy and strong, then your heart rate doesn't need to be as high. The vascular system, we talked a little bit about it. Your arteries are carrying oxygenated blood for the most part away from your heart. Veins are coming towards your heart and for the most part carry deoxygenated blood. Eventually they branch into the smallest part called arterioles, which then lead into capillaries. And capillaries are where we have your gas exchange going forward. Oxygen and nutrients pass out of the capillaries and into the cell, and carbon dioxide and waste products such as lactic acid pass from cells to the capillaries by diffusion. After oxygenated blood has been delivered, capillaries then return to venules and veins and back to the heart and the lungs to get reoxygenated. The walls of blood vessels are composed of 3 layers of tissue. Smooth, thin layer of the lining is called the tunica intima or endothelium. The middle layer is the tunica media is composed of elastic tissue and smooth muscle cells that allow the vessels to expand or contract in response to changes in blood pressure and tissue demand. And in the thickest of the 3 layers is the tunica advententia and consists of elastic fibrous connective tissue. The heart has its own circulatory system, which supplies it with oxygen and nutrients. They are supplied via the coronary arteries, which arise from the aorta shortly after it leaves the left ventricle. Coronary arteries receive their blood supply during the diastolic phase. So when the heart's relaxed, that's when it's becoming oxygenated, that muscle tissue. Coronary circulation emanates from the left and the right coronary arteries. The left main coronary artery is the largest and shortest of the myocardial blood vessels. It rapidly divides into 2 branches, the left anterior descending and the circumflex coronary arteries. When those arteries, if they happen to get blocked, that's when you have a myocardial infarction or a heart attack. On page 270, some diagrams just showing a greater, you can see the gas exchange at the capillaries. Again, those are diffusion, higher concentration to lower concentration, so it's passive. You can see the anatomy of your vessels. So there's your endothelium, your smooth muscle and elastic tissue, and your connective tissues. And then on 271, you've got your diagram showing the blood supply for your heart, your coronary arteries, and veins. 277 shows a full diagram of your major arteries and veins. You can see where they are, and I think understanding the location of those is super important when you're dealing with trauma and possible potential internal and external bleeding. We should all know by now if we have blood that's spurting, we know that that blood is under pressure, so we're looking at an arterial bleed, where if it's more dripping, we're talking about a venous bleed. Understanding the larger ones are going to be able to lose blood at a more rapid rate because of their diameter. So your femoral arteries and veins are ones you want to know, kind of have a general idea of where you're going to see those. Your brachials and your upper carotids and those larger veins and arteries up here. Just understanding where those larger ones are so that you can keep that in mind as you're doing bleeding control. Anything else on those? Okay. And then the diagrams on the other side just kind of take a look at more specific locations for your arteries. So you got your carotids. So understanding even where you want to feel for your pulses is important. We all know that the carotid is going to be a big one for us. That's typically the first go-to that we have. If you're not able to find those, you've got your brachial pulse. And being able to kind of have that bone to press the artery against kind of gives you the ability to feel it a little better. And then in your femoral arteries, you're going to press it against your femur to feel it. Brachial and pedal pulse, or your brachial pulse is here. Your, what's the pulse on your wrist? Radial pulse. And then your pedal pulse on your foot. Those are all places that will give you information about your blood pressure. If you can't feel it in your extremities and you don't have the ability to get a blood pressure, and Jim, you're better at this than I am, but you can kind of get a guesstimated reading on blood pressure depending upon where you can locate pulses. Is that right?
If you got a radial, you got at least 80.
So if you got a radial, you got at least an 80 systolic?
Yeah, that's kind of the one rule.
Okay. So if you're not able to get it on the radial pulse, then you know that you might have some issues with low blood pressure, which could be just the loss of blood volume. Having a general idea of location of veins will also help you with your selecting a site for an IV. I've tried it on the foot unsuccessfully, not very often. I typically The only reason that you'd probably wanna look there is if you either can't get it anywhere else, or maybe you have some trauma to the, arms that allow you to have to look at the foot for potential, venous
Of course,
access.
now we have a new,
Yeah, the IO.
yeah.
I'm ready to practice those again. All right,
You might
moving-
tell Tinsley what an IO is, they probably know.
Oh, IO is an interosseous. You can set up an IV by gaining access to the bone marrow and pump IV fluids directly into there. The nice thing about it is that if you know how to put it in right, it's foolproof. You're not gonna blow a vein and have the IV not be usable anymore. You don't have to worry if there's trauma to the veins. It's foolproof, isn't it? For the most part, if you get it in the right location.
Yeah, it works really well, I mean, for a tough, it's the tibia, proximal side of the tibia.
Yeah, proximal side of the tibia, so I don't know if you can see, but inside part, there's a flat part, and we'll learn how, I'm assuming they'll teach us how to.
Yeah, that's gonna be next week.
Is it next week?
Yeah.
Ooh, Tyler. So,
Or the next class that we have will be
next class that we have, we'll be doing that. So, we'll get practice with those. Those are pretty cool, but they are like any other thing. You just have to get used to trying them and get brave. I think an unconscious patient is the best person to try it on, because they're not gonna yell at you. Because I don't feel like they probably feel very good. I've only done one in all my years, and that was with somebody holding my hand in the ER, so I'm gonna get brave and try one.
It's a tool we just kinda got 2 years ago,
Yeah,
so.
we don't have a lot
Tried
of.
to do one.
I did, the battery was out,
Or
dang it,
battery.
I wished in hindsight I had just shoved it in there, cause they weren't gonna know.
Ow.
Next time, I'll do it.
That would've been a try.
It would've.
Instead of just
I
stabbing it with
think,
the
I
needle,
think we
being
made
like,
a
"Oh,
try,
no,
but I think our
dead."
battery was out, so.
It was, yeah, we're gonna get there, we're gonna get there. Next couple of chapters talk about the difference between white blood cells and red blood cells. Red blood cells are our oxygen carriers and our carbon dioxide carriers. They are referred to as erythrocytes. Bye, guys.
Highway 20 South, 57-year-old female cell this morning is requesting an ambulance.
That sounds like a familiar address.
Have fun.
Brandon, there's a fat naked lady.
Bye. So they're off to an ambulance call, they'll have to catch
I
up.
don't want to, but I'll come help you.
Yeah, you just wanna get away from me, whatever.
Not so much you,
No,
but
you just wanna stop at McDonald's on your way back.
Yeah, I need to my life.
I do wanna read a little bit on this part of the red blood cells at the bottom of page 276. Erythropoiesis is the ongoing process by which red blood cells are made. In hypoxic states such as anemia, red blood cells production is increased. Red blood cells have a finite lifespan of only 120 days. Those cells destined for destruction decompose in the spleen and other tissues rich in cells known as macrophages. So macrophages are recyclers of red blood cells. The part of the hemoglobin that is not recycled is converted to bilirubin, which is a waste production that undergoes further metabolism in the liver. If your liver is not working the way that it should be, that bilirubin is not filtered out. That's when you might see yellow coloration in their skin and the whites of their eyes. A lot of times, if the infant's liver is not quite working the way it should when it's first born, or premature infants will oftentimes fight this. The bilirubin's not being able to be cleared by the liver. They'll put them under biliolites, which helps break that waste down and get
So it's the
eliminated through
presence
the
of the
body.
bilirubin that causes the appearance of jaundice, is that right?
Yep. And so, like, if you have a bruise, and you'll notice after time it'll turn like a greenish and then a yellowish, that's the red blood cells that were damaged are being digested by the macrophages, and that's bilirubin around there. And then as it's fading, that's your body getting rid of it. But alcoholics, a lot of times you'll notice that yellowing color because
Right.
their liver's just not able to clear that bilirubin. So that yellow jaundice color is due to bilirubin, yep. So red blood cells have antigens on their surface, which are proteins that make your blood type either A or B or O or AB. And then they also, in the plasma, have antibodies. So understanding antigens and antibodies, you have to kind of be heads up on that, because if you're doing blood transfusions, which we won't do in the ambulance, you have to be really careful to make sure that you're giving a patient blood that is compatible. So type A blood are going to have antigens on their surface. They are going to have, they're going to have A antigens on their surface. They will have anti-B antigens in their plasma. So if you were to introduce B-type blood, those antibodies are going to attack those cells, okay, and kill them. It's just going to cause havoc in the body. Likewise, B blood is going to have B antigens on their surface. They will have anti-A antibodies, giving a person with type B blood, type A blood is a terrible idea. Some people have both A and B antigens on their blood cells. That would make them AB. And they do not have antibodies in their plasma. So AB people can actually receive blood from A, B, or O. So they are what we call the universal recipient. Now, I'm just talking about antigens on the blood. There's also the RH factor that I'm not going to talk to you about, but it's something that you also have to be mindful of. RH factor has, if you're RH positive, you've got no antigens or antibodies. I might have this backwards. And if you're RH negative, I can't remember the difference. I'll read it here in a minute. O blood has no antigens on the blood cell. They have both A and B antibodies. So O can give blood to anybody. They are the universal donor, but they can only receive blood from other O patients. So let me read the part about RH so I don't screw us up. Another antigen called RH antigen can exist on the blood as well. A person can have RH factor, a specific type of RH antigen present in their blood, or not. They can be RH positive if the antigen exists, or RH negative if it does not. This can be very problematic in pregnancy. The fetus inherits father's RH factor, so when the mom who is RH negative is pregnant, while the child who is RH positive, the woman's body will produce antibodies if exposed to the RH factor. Those antibodies then can attack future pregnancies if the fetus is RH positive. So I know that they used to, I don't know if they do it anymore, test for RH when you're pregnant. I haven't been pregnant in 18, 19 years, almost 20 years, so I don't recall. But I know that that's something that they have to pay attention to as well. For white blood cells are known as leukocytes, and they're your little army in your body. They're going to fight any foreign bodies. So white blood cells are motile, which means they go where they're needed. They move around your body in a process called diapedesis. They move where the issues are. So interesting story. My sister, who's had heart problems her entire life, had a really bad infection, and the doctors could not identify where the infection was. So what they did was they took some of her blood out and radiated all of it, white blood cells included, and then when they put that back into her body, they were able to follow the radiated white blood cells to where the location of the infection was. So I thought that was really interesting. And they were able to help her get better because she was a sick puppy. White blood cells are named according to their appearance. So if they have little granules in them, they're called granulocytes. If they do not, they are called agranulocytes. Neutrophils are a type of white blood cells whose job is to destroy bacteria, antigen-antibody complexes, and foreign matter. Eosinophils are granulocytes that function in allergic reaction response. Basophils are your least common. Basophils contain large amounts of histamine, a substance that increases tissue and inflammation, and heparin, a substance that inhibits blood clotting. Lymphocytes are the smallest, and most lymphocytes are located in the lymph nodes, spleen, tonsils, lymph nodes, and thymus. Monocytes and macrophages are among the first line of defense in the inflammatory process. Monocytes migrate out of the blood and into the tissues in response to infections. Platelets are also found in the blood, and they're structures that assist in hemostasis or blood clotting. Eventually, thrombins are also part of that clotting factor, and fibrin. And all of that will help create the clot. When it dries, that's what you're looking at when you see scabs. The circulatory system, we know that the pulse is what we look at in order to assess how fast the heart is beating. Blood pressure is the pressure that is exerted on the walls of the arteries. We already kind of talked about that your systolic pressure is when the heart is empty, and your diastolic pressure is when it's relaxed and full. Sphygmomanometer, I have a heck of a time saying this, is just the tool you use to measure blood pressure. If you're doing it manually, otherwise you're using an automated cuff. What?
How did you say that?
Sphygmomanometer. Shut up, Tyler.
Be nice.
Do you want to make it to 21?
Fine.
If somebody's got to get her.
Your mother's being very nice. You better be nice also.
Perfusion is just the body's ability to become oxygenated. If you have good perfusion, you recognize things like the color is pink, the lips are not blue. Capillary refill, if you're getting good perfusion, you can press on, you would do this with children, press on the finger, push all the blood out, and then when you let go, you'll see that it returns to a normal color quickly. That's a good sign of appropriate perfusion. Sometimes inadequate perfusion will happen when a patient is in shock. Things to look for when they are not properly perfused, you'll see pale. If somebody's pale, then you know that their perfusion's not good. You might notice a blue coloring to the lips. If a patient is bleeding severely or dehydrated, baroreceptors, remember those are the ones that respond to pressure, will sense an abnormally low volume of blood in the circulatory system. Although severe, several different body responses can occur at once. A major response is the release of epinephrine and norepinephrine from the adrenal gland, causing a sympathetic stimulation resulting in increased heart rate as well as increased myocardial contractility, which just means that your vessels will contract and get smaller, which then makes it pump through the body more efficiently. Because if you've got a larger vessel and they're not working very good, or you're low, you don't have a lot of blood volume in there, with the pumps it's not going to move through like it should. So having those smaller vessels helps move the blood along, and also shuttle blood where it's mostly needed in your vital organs. Talk a little bit about the lymphatic system. It's a plasma-like fluid in the interstitial spaces. It plays a big part in your immune system. On page 281, you see diagrams showing your lymphatic system. Your lymph nodes, a lot of times, if things are not going well and they're carrying extra volume, because of that, you'll see them swell. So you'll find sometimes a swollen lymph node can be under your arms, in your groin area, behind your neck and your ears, where you have, like if you have swollen tonsils, or you might feel lymph nodes here. And all of those are signs that your body's fighting something. Nervous system is next. You've got your central nervous system, which is your brain and spinal cord. And you have two parts of your somatic nervous system is the part that regulates activities that are voluntary. So you have control of your somatic nervous system. I touched something hot, but it's not super hot, so it's not a reflex, so I'm going to move my hand because it's uncomfortable. I'm hungry, so I'm going to eat, those types of things. Then you have your autonomic nervous system, which controls things that you aren't consciously thinking about. Oh, hey, my heart's gonna beat. So my autonomic nervous system controls that, so I don't have to sit here and focus on keeping my heart beating, because if I'm gonna try to multitask, I'm in a whole lot of trouble. So the brain is the main organ of your central nervous system, and then you also have your spinal cord. It talks a lot about the parts of the brain. You've got your cerebrum, which is the largest part, sometimes called gray matter. The cerebellum, which is located underneath the larger mass, sometimes called the little brain. Its function is to coordinate various activities in the body movements. The cerebellum specializes in muscular activities. The brain stem is the most primitive part of the central nervous system. The brain stem comprised of 3 areas: the midbrain, the pons, and the medulla oblongata. One of the interesting operations of the brain stem is that it regulates consciousness. If you look on page 282, you can see some of those in the diagram. So the cerebrum is your largest part. They've got the brain stem kind of all bracketed in there, where your pons is the kind of bubbly part. Then you have your cerebellum, which is kind of tucked back behind your occipital. Then the cerebrum has different parts. You've got your frontal lobe, your parietal lobe, your occipital lobe, and your temporal lobe. And they've got diagrams in there showing you like the conscious thought, primary motor area, speech and smell are all part of the frontal lobe. Your hearing and reading are in your temporal lobe. Taste, primary sensory area, body awareness and language are in your parietal lobe, and your vision is in your occipital lobe. Then you got your spinal cord, and we talked about how it's protected by your spinal column and your skeletal system. The entire central nervous system enclosed by a set of 3 tough membranes known as meninges. The outer membrane is the dura mater. The second layer is that arachnoid, and then the pia mater, which is the innermost layer. Then you've got cerebral spinal fluid, which kind of helps protect and wash the brain. You might see cerebral, it's clear, but you might want to be heads up on it. If you have some head trauma and you see clear fluid coming out of the ears, suspect that's cerebral spinal fluid coming out of their ears. That is not a good sign. On page 284, you can see the diagram which shows the spinal cord, and then you can see all of those nerves exiting the spinal cord and going to all parts of the body with different types of receptors. Some receptors might be for temperature, some might be for pressure. They all have their different jobs. So like even in the spinal cords in the brain, that are the nerves in the brain that go to the eyeball and the hearing, they all have their different job and different things that they pay attention to. There's pain receptors, so your skin has just a multitude of different receptors in it to collect information about the environment and send that information to the brain so that it can respond accordingly to maintain homeostasis. Words of wisdom, let's take a look at those on page 284. The first one, bleeding can occur between the meninges and the brain, usually as a result of trauma. The most common type of bleed occurs within the subarachnoid hemorrhage, in which the blood lies between the arachnoid and the pia mater. And that, I might have to go back and look at. That's really not found on any of the diagrams I'm seeing so far. Words of wisdom on the bottom. The patient with a fracture at the base of the skull, CSF, can leak, so cerebral spinal fluid can leak into the eustachian tubes, past the eardrums, and out through the ears. Because CFS does not mix well with blood, it sometimes appears as a halo of clear fluid around drops of blood when it leaks into gauze. CFS that leaks into the back of patients' throats is often described as having a salty taste. So your peripheral nervous system, many cells have long fibers that extend from the cell's body through openings. These cables of nerve fibers make up your peripheral nervous system. So those are the nervous systems that go out all to your body and collect information about it. Other portions of your peripheral nervous system might be your sympathetic nervous system, which is your fight or flight. I'm not seeing where they talk about your limbic system. Let's go back up. The limbic system is also called the emotional brain. In sports, we refer to it as your lizard brain because it's your flight, or it doesn't kick in with your fight or flight. So that's when your emotions control your behaviors because your limbic system is kicking in. It's not always working in your best favor if you're trying to overcome your fear. As an athlete, I know we talk about how you've got to combat your lizard brain. Sensory nerves, those are the ones that are your pain receptors, your temperature, taste, sight. Then your motor nerves are the ones that work in unison with your muscles, so that your body is doing what you want it to do. Then you have your spinal reflexes, and those are nerves that don't necessarily go all the way to your brain. They're the ones that there's not always enough time to react. They're quick to work. If you touch something hot and it's damn hot, and you don't want to be hanging out there thinking about it, your reflex system's going to kick in and send the message to your muscles to move your hand, and that all happens without going clear back up to the brain. Words of wisdom on 285. In the brainstem, most nerves cross from one side to the other. Motor and sensory nerves on the left side of the brain, for example, serve the right side of the body. That's why a person who has a stroke or sustained trauma in one hemisphere has nerve deficit on the opposite side of the body. Because the cranial nerves are above the crossover point, their function will be affected on the same side of the body. The same as the injury or the stroke. So I think understanding that is certainly something as an EMT we need to be aware of. Talks about cranial nerves. Those are the nerves that are found in the brain that are collecting information about the brain's environment. The ocular nerve is collecting information from what you're seeing. Your olfactory, your smell nerves are going to be up there. Your vagus nerve provides function from the soft palate, pharynx, and voice. Vagus nerve carries sensory fibers to the inferior pharynx, larynx, thoracic, and abdominal organs. Talks about the eye. I guess I could go into basic anatomy of the eye. So the optic nerve is the nerve that goes directly from the eyeball back to the brain. It is connected to your retina. So your retina is a thin layer of tissue, a nerve tissue, at the back of your eye. Sometimes people who have detached retinas will see that kind of floating across their vision. And all that does is it absorbs light. The cones absorb color, or detect color, where rods detect black and white. So if you're walking around at night and you don't see a whole lot of color, that's because it doesn't take as much light to stimulate rods as it does cones. So you're gonna need enough light to stimulate those cones before you're gonna detect color. Your iris, or your pupil, the iris is the colored part of your eye. Your pupil is that hole in the center, and you'll notice when we, as an EMT, are checking reactivity of the pupil, all that does is control the amount of light that enters your eye and lands on the retina. So if you walk outside and it's super bright and it hurts, that's because your pupil has not dilated or constricted quickly enough, and you're getting too much light on your retina. And it isn't always pleasant. If you're looking at somebody and it's dark, typically their pupils are going to be bigger because they're trying to absorb enough light to be able to see. Drugs and alcohol will affect, and sometimes brain trauma will affect the reactivity of your pupil. You'll notice sluggishness. Maybe their pupil is dilated when a normal person's wouldn't be, because the drugs are affecting their ability to have an appropriate pupil size. So those are things that, as an EMT, we take a look at quite a bit. The tegumentary system is your skin. Your skin's the largest organ in your body. It's got layers. So the superficial or top layer is your epidermis. It consists of layers within that epidermis. Your dermis is your deepest. It's the deepest layer is your dermis. The main function for your skin is, number one, to protect your body from the environment. Temperature control. Injury. So if you pay attention, your skin's going to be thicker in some areas that are in contact with the environment more than others. So there's different thicknesses and toughness of skin in appropriate places. On page 288, you can see a diagram of your skin. So hair grows out of the skin. That muscle, the erector pili, if you get goosebumps, your erector pili has contracted and pulls that hair up. The reason it does that is trying to trap the hair, use the hair to trap heat. Also, moving muscles produces heat energy, so goosebumps kind of try to help you conserve heat. That way you might get shivers because you're trying to produce enough heat to keep you warm. And all of these receptors telling you about your external temperature are found in your skin. You'll also find sweat glands, subcutaneous fat. When we get into assessing burns, we talk a lot about the layers, and using your knowledge of the layers helps you kind of determine the severity of the burn, which in turn will help you treat the patient appropriately, and we'll review that, I'm sure, later in the class. So 289, words of wisdom. Considerable damage to the skin may make the body vulnerable to bacterial infection or invasion, temperature instability, and major disturbances of fluid balance. That was the other one I forgot, which is precisely what happens when injury results in the opening of the skin. The next one down, skin, the largest single organ in the body, serves three major functions. It protects the body from the environment, regulates temperature, and transmit information from the environment to the brain. Then you have the digestive system. Understanding the quadrants, there's 4 quadrants. Looking at the diagrams, you can kind of, your abdominal cavity is what carries all of your digestive system. You got your stomach, your large intestines, your small intestines, your cecum, your appendix. Digestion starts as soon as you begin eating, with salivary glands that help start breaking down starches in your mouth. The oropharynx is the tubular structure that extends vertically from the back of the mouth to the esophagus and trachea. The esophagus takes approximately 10 centimeters or 10 inches long, extends from the pharynx to the stomach, and lies just anterior or behind anterior, which is in front of the spinal column. Smooth muscles in there help move food down into your stomach. The stomach then starts to introduce food to more chemicals that break it down and begin to digest it so that what needs to happen in the next part of the process is able to start. Hydrochloric acid in your stomach starts breaking it down. Your stomach has a lining which protects it from being processed by the hydrochloric acid, and sometimes if that wears too thin, you're going to have some pain, which is an ulcer. The food, once it's kind of starting to digest, so you wouldn't really call it food, but it's not poop yet, it's called chyme. And then it moves to the pancreas is part of the digestive system. It secretes stuff that's pancreatic juices, which help to aid the process of digestion. The liver is one of the larger organs, takes up most of the area beneath your diaphragm. It's both in the right, it's mostly in the right, but extends into the left upper quadrants. It's the largest solid organ in the abdomen. Because it's solid, it's a little more susceptible to injuries, to blunt trauma. Its job is to filter blood. You got your gallbladder, which secretes via the bile ducts. Some people will have their gallbladder removed. You can also have gallstones that might cause pain, and you might get an ambulance call because somebody's dealing with gallstones. The small intestine. Small intestine is where you're going to have absorption of major site for chemical breakdown of food, major absorption of water, fats, proteins, and carbohydrates. Then it's going to move to the large intestine where water continues to be absorbed, formation of feces, bacterial digestion of food. Then the anus and rectum is where the last product of the leftover food is controlled by a sphincter, which releases the feces, and you have a bowel movement. The table on page 711 does a pretty good job of reviewing all the major parts of the digestive system from the mouth down to the gallbladder. The gallbladder just stores the bile. Endocrine system is a complex message and control system that integrates many body functions. Is there a table for that that reviews it all so that I have to read all of it? Not really. It's going to be controlling your hormones. You've got the exocrine glands and the endocrine glands involved, your thymus. The diagram on page 293 kind of shows some of the organs that are part of this system. Obviously, some sections of the brain are going to help control it, your pineal gland, your hypothalamus, and your pituitary. You've got your thyroid and your parathyroid, your adrenal glands, which are connected to your kidneys, your pancreas, then your ovaries and testes. All of those play a role in your endocrine system. It talks about the specific jobs of the different organs. I'm not going to go over those. If we talk about pregnancies and human development, we'll probably get into your sex chromosome or your sex glands and hormones there more in depth, I'm assuming. You got your urinary system, which controls the discharge of wastes that are in the liquid form. Kidneys play a big part of filtering your blood and helping remove those wastes. The ureter is the pathway from the kidneys to your bladder. Your bladder then holds the waste until it's full enough that you're going to eliminate it by micturition or urinating. For men, your prostate gland is
pain?
a pain. It's in between your bladder and your penis, and if it starts to swell, it can interfere with a man's ability to urinate. So sometimes you may have patients who are dealing with that frustration. Anything to add to that, guys? I don't have any experience with it.
Tequila and beer work pretty good to keep it.
Do they? Nice.
What does?
Tequila and beer.
Tequila and beer, I missed that one.
Words of wisdom on 296. The kidneys also are important in the regulation of the body's fluid balance and blood pressure. Talked a little bit earlier about output of your kidneys. The kidneys kind of help control how much liquid or water we remove from the blood or leave in the blood depending upon our hydration level. They perform vital functions in the conjunction with complex hormone-driven mechanisms. Fluid balance is controlled by the effects of ADH in the kidneys. The blood pressure effects are influenced by the renal antigen system, in which the kidneys are an important part. So you got male anatomy and female anatomy, which I'm not going to go into.
Good enough.
No, we wanna hear the birds and the bees, Amy.
I'm not teaching you the birds and the bees. We can call Shannon Hill if you want.
You guys noticed that our crew's the only one?
Yeah.
Yeah, I know. Good
So
deal.
that
Crew.
pretty much gets us through chapter 5, the life support
crew.
chain.
Chapter 7, yeah.
Yep, so chapter 7 is
Um,
kind of done.
Dr. Bright is hung up at the ER, as we know, since we just had an ambulance page. She's had several walk-in patients and will not be able to
Join us.
get here for a while. I think we've kind of covered the material that we need to cover up to this point for today.
So we're not doing chapter 8 and 9?
I think we'll look at 8 and 9 probably on the 29th, which is our next meeting date, January 29th.
Because you said the test only goes through chapter 7.
The test is only going to go up through chapter 7. It'll be that first section. And then next week is going to be the section on pharmacology. Primarily, we'll be talking about IVs. It'll be chapters 12 through 14 in this book. When I did this sheet that I initially sent out, I didn't have the book that Mark had chosen yet.
So we're thinking we'll do 8 and 9 and then 12 through 14 that weekend?
Yeah, we'll do 12 through 14. It's actually section 5 will be the most important thing. And that'll be the weekend of January 29th, January 30th, January 31st. And hopefully our guest speakers will make it here, so you don't have to listen to us.
Yes.
Amy did a great job. Thank you
Yes,
very
thank you,
much
Amy.
for being a real team player on this deal.
All right, so review quickly chapter 8 and 9.
Yeah, we'll look at that just quickly.
And then,
If there's anything that's pertinent.
what chapters did you say, 11 through 14?
12 through 14. It's
12
section
through
5 in the book. And it'll be on IVs, get us started on all those things.
All right.
And I believe we've got lab, there will be a lab on that Sunday, hopefully, if the hospital gets it set up. Some of us will be bleeding somewhere. 10 sleep, I'm not sure how we're going to do that with you guys when we go to start sticking. I did get, it's Sarah and Annie, or Ann.
You received nods. I just signed in.
I got nods? Okay, good deal. I've got your information. I'll be sending out a deal to everybody about everybody that's in the class. It'll have text or your cell phone numbers and your emails. I will be sending out that test before the next class. I'll send it out possibly here this next week if I get my tail in gear. And I'll get that sent out so you got plenty of time to look at it. You got 2 weeks, which gives you a lot more time to do some reading prior to the class. We just got the books. It was a stretch to get the reading done. I know.
Much about that.
Does 10 Sleep have books?
Yes. Yeah.
Oh, I heard them.
Wow, yay.
Oh, wow.
Tyler, turn the speaker on.
No.
Well, good. I'm glad you've got books. Do you have any other questions then? All right, well, thank you guys for putting up with us today. Hopefully we got a lot more to offer you in the future. We'll kind of keep working on this thing. So thank you very much.
Thank you.
Have a good
Have a
one.
good Sunday.
See ya.
So.
I had a clipboard in here that had, right there. Oh, okay. Wondered where it was.